Phyllis, you are the director of the Lung Cancer Alliance of New York, and before you got on the line, we mentioned that obviously this is November's Lung Cancer Awareness Month. Obviously, you're very much involved in it, both professionally and personally. So let's talk about, first of all, just give us a brief understanding of what the Lung Cancer Alliance does do here in Albany.
All right, the Lung Cancer Alliance, we work to eradicate stigma that's associated with lung cancer by raising awareness and have education, such as the Vigil. Also, to promote our Lung Cancer Alliance patient support services, which are provided through our national office, and there are several of them. Did you want me to spell them out now?
Well, just tell us,
and also to change public health policy, because lung cancer has been an orphan cancer, and we need to pay attention to it.
Well, Phyllis, when you say it's an orphan cancer, what does that mean?
Because of the stigma, not much research funding from the federal government has been put into it, whereas for breast cancer, there is a lot of research funding and getting results because people are recovering from breast cancer, whereas twice as many women die from lung cancer as breast cancer.
Well, as I understand it, that one of the things with lung cancer is, and the stigma that's associated with it, is because we tend to blame the victim, that if you hadn't smoked, then you wouldn't get cancer, and so we don't want to, invest too much money or time in this disease, where breast cancer, you don't blame the victim in the same way. So there is that stigma associated with it. But you never smoked and were diagnosed with lung cancer how many years ago?
Right, 10 years ago. And thank God it hasn't come back. And I lost my best friend, Susan Sherman, who was a professor at the School of Social Welfare, to lung cancer, and she was a never smoker. And when I was in a doctor's office reading a newsletter from the Lung Cancer Alliance, I saw a notice that said, "We need advocates. If you want to be an advocate, call this number." And so I said, they're talking to me because I owe it to Susan and I owe it to myself to help others by advocating for lung cancer.
Well, the statistic that I have here, lung cancer is the leading cancer killer in the United States, taking 160,000 lives each year, and 15% of people diagnosed with lung cancer will survive it. And primarily the reason for that is, and this is something I guess you're working against, is that it isn't diagnosed until late stage. So
that's correct.
So I guess one of the goals of the Lung Cancer Alliance, as you say, is to be aware, to know what are some of the symptoms of lung cancer.
The symptoms?
Mm-hmm.
Some of the symptoms are coughing, shortness of breath, wheezing, hoarseness, coughing up blood, fatigue, chest, shoulder, back, or arm pain, and pneumonia.
Now, are these symptoms after it's already a late stage diagnosis, or is that an early? If they have a coughing, is that something that could be found in the early stages, or usually is the more symptoms usually the later stage?
Well, you get more symptoms at a later stage. Some people never have symptoms. I had an occasional cough and didn't think anything of it, but it didn't go away. And then this was 6 months after Susan was diagnosed, and my husband said, well, you better get that taken care of. Go to the doctor. And I thought he was overreacting, but I gave in and I went, and I was diagnosed with stage 3A lung cancer.
How did they diagnose it? What did they do? You get a CAT scan or what?
Yes. right, you get a CAT scan, you get a biopsy, and then we take it from there. I was lucky because my cancer was operable, and that's considered the gold standard. If it isn't operable, it means that it has metastasized, most likely, and therefore is not something that they can cure, but just treat to alleviate the symptoms.
Phyllis, what's it like living with lung cancer? I mean, once you're diagnosed, I mean, you're talking about 10 years. Because it seems to me, and I think that people would like to hear your story, that, one would always be frightened that it's going to come back or that you have to have a continuing treatment all the time. I'm sure each case or each person's story is different, but what's been your experience?
Well, I've been really lucky because after my surgery, I had chemotherapy and radiation, and that took care of any remaining microscopic cancer cells that were in my body. And I have been lung cancer free for 10 years. And I get scanned every year to make sure everything is okay. But yes, every time I get scanned, there is a worry that they're going to find something, because that's why you're getting scanned. They're looking. So that raises anxiety, but I've been lucky so far.
How do you feel about support groups for lung cancer survivors?
Well, I think they're important, and the Lung Cancer Alliance has an online community, and people can dial in and get support and find out about resources and ask questions. It's called Lung Love Link. And also we have a peer phone buddy program where a person who's had your experience, they try to match you up with your particular type of diagnosis and experience with someone else, and that person is to help you get support, and not only for patients, but for family members and caregivers.
Well, I'm sitting here with my co-host, Alyssa Lotmore, and she's an MSW graduate from the School of Social Welfare. And I think, Alyssa, didn't your aunt, she was diagnosed and died of lung cancer just recently, her husband? So you're the family. Give us some of the family perspective, as Phyllis is talking about.
It was definitely, I always hear, it was sort of the first real cancer experience in our family that I actually witnessed the whole process. And it was something that was very traumatic, especially not only for my aunt's husband who was suffering, but for her as well, to see a deterioration. And I like, Phyllis, how you said that the organization also offers support for family members, because watching someone deteriorate like that was, for me, who wasn't even in the house often, was hard to watch. And to have someone have to go through that every day in the caregiving role is definitely a traumatic experience. It really is different types of grief and loss that you're going through the whole process. Because it's sort of it's not just a sudden, something happens and you are moving on from there. This was on for over a year and a half of this constant deterioration, and with knowing the end result, it was told that it was non-operable. It was told that it was going to be terminal, and just that process alone was very, very traumatic.
Well, Betsy McPhail, who is sitting there.
Can you see her?
She had 2 caregiver experiences. You might want to ask her about her experience and how she found hope through her. She built up a huge support group. You might ask her how she did that.
All right, let's go, Betsy. You tell us, how did you do that?
How did you start the support group and your experience going on through this?
Well, for me, the diagnosis and my sister's story came completely out of the blue. I don't know if we should start with a little bit of background.
Yeah.
My sister was a normal 24-year-old, working her first job after college, training to run a marathon, perfect health, no risk factors. All of a sudden, she couldn't breathe. She went to the doctor and was misdiagnosed for several months because normal 24-year-olds with no risk factors don't get lung cancer. So eventually she was diagnosed with lung cancer, and it was stage 4 lung cancer, and it came out of nowhere. So we didn't really have time to think about anything. We just had to react, and part of that was reaching out to people and sharing our story. I think people connect, and they feel like it could happen to them. And a lot of my friends are the same age as as me and my sister, and they felt a real connection to it. And it was just sharing our story and talking to them and slowly building up from there. And then I get involved with the Lung Cancer Alliance, and they have some more formal programs and support structure, and it was really great.
What are the statistics for someone who's 24 years old? Or maybe you don't know, I don't know if you know them or not. I mean, what's the average age of diagnoses? Because it would seem to me, as you said, like you're 24, doctors aren't going to be looking for lung cancer. It's going to take time probably before they make the correct diagnoses.
Phyllis might know the statistics better than I do,
right.
But unfortunately we're seeing more and more young women in their 20s, 30s, 40s with no risk factors getting lung cancer, and it comes from a genetic mutation.
Mm-hmm. What about environmental carcinogens? I think that's another area they're beginning to explore, right, Phyllis?
That's right. Not only environmental carcinogens, but radon. I mean, that's something you need to check your house for, because that's the second leading cause of lung cancer after smoke. So that's something that everyone needs to check out.
I think I have one of those radon detectors in my closet, but I don't know if it's working or not. But after this show, I think I'm going to run home and find out whether it is.
And take it
seriously.
Right. I just wanted to say that we were talking about never smoking women with lung cancer. Over 25,000 women who have never smoked will be diagnosed with lung cancer this year.
That's a very high statistic. I didn't realize it was that high.
25,000?
Yes.
Yeah. And I imagine there are different parts of the country that have more, there's more lung cancer than in other parts of the country, which would, the carcinogens are, for instance, I don't know, I think New Jersey, some of those cities were highly industrialized states, et cetera. I just want to talk about the lung cancer. I mean, it's Lung Cancer Awareness Month and the Lung Cancer Alliance, exactly what you do. I mean, we've sort of been sharing these personal stories, but the Shine a Light on Lung Cancer Vigil. Now, what is that?
Yes. All right. That is a program that's designed to help provide compassion, support, and hope. We have a program where Dr. Thomas Fabian, who was unable to be with us today, he's Chief Thoracic Surgeon of Albany Medical Center, and he will be speaking on the U.S. Preventive Services Task Force grade of B for early screening of high-risk people. What that translates into is that the grade of B will encourage insurance companies and Medicare to adopt protocols for early screening of high-risk people. And also he will talk about new treatments for lung cancer.
Okay, so that's what Dr. Fabian is going to do. Now, what are you going to do, or what are the general public? How do they get involved in the Shine a Light on Lung Cancer?
All right, well, I just wanted to say that's just one part of it. And then a former caregiver, namely Betsy, and a former smoker who gave up smoking when she had her diagnosis, and I, a never smoker, will talk about how we found our way to hope after the diagnosis. And the former smoker had to cope with feelings of guilt because she blamed herself for her lung cancer. And it's not yourself to blame She tried to give up smoking 12 times. It's the tobacco companies who are at fault, who make the tobacco more and more addictive.
Maybe we all have to take responsibility, personal responsibility, the responsibility of our environment. I mean, it's kind of like it's a big mix. But the actual vigil is going to be what, at the Albany Medical Center, Hilton Garden Inn?
Yeah, Albany Medical Center, Hilton Garden Inn, on Thursday, November the 14th. And there will be a free cocktail reception at 5:30. Followed by the program, which is free, at 6:30. And there will be registration if you want to pre-register. You can go to albanyvigil.kintera.org. And Kintera is spelled Kintera. And someone from Congressman Tonko's office will be talking about the Recalcitrant Cancer Research Act, which was passed. You know, we talked about how lung cancer is an orphan disease. Well, this Research Act designates pancreatic cancer and lung cancer as a national priority and asks the National Cancer Institute to set up a research framework for these diseases in particular, as well as others that have less than a 50% survival rate. And so we'll have a representative talk about that. And then there will be a ceremony where we light glow sticks, and there are photos shown in a slideshow of loved ones. And that's very moving. And people can submit their photos to L. Boyd, spelled B-O-Y-D, at lungcanceralliance.org.
Right, that kicks off the year in November 2013 to 2014, I guess, really, for Lung Cancer Alliance. But how do you keep this thing going? You know, people get on the bandwagon very often for these groups, for the meetings, and you know, everybody gets excited, and then it tends to or will die down after a while. And so how do you just keep the enthusiasm going so that we do something about it? And have we made a lot of progress, let's say, from last year, in your opinion, in terms of diagnosing and treating lung cancer?
Well, I think we did, in that we got the Recalcitrant Cancer Research Act passed, and we'll be making a lot more progress with the grade of B that I referred to earlier, and then we need to promote that to people who are at high risk, so they will get themselves screened.
Phyllis, what can social workers do? I mean, we're social workers. We're here at the School of Social Welfare. This is our show. So specifically, you're sitting here with two social workers, MSWs, and we do very different kinds of things, really, with our degree, besides the radio show, Alyssa and I. What can we do? What can we promote? Because social workers should be in the forefront of this, as far as I can see.
Right. Well, I think one of the things that the social workers can do is to familiarize themselves with the patient support services that are being offered by the Lung Cancer Alliance. And we have a support information and referral line, a credible website, and a clinical trial matching service. We would like social workers to be familiar with what's available, refer people to those programs, and be an adjunct support to that.
So it's really important that the professionals, social workers, not just doctors and nurses, but those in the allied healthcare professions also are aware and know where to go and what the resources are. Betsy, what about you? Did you have any help when your sister was diagnosed, 24 years old? You're a caregiver. You're part of the family. Were you involved with any social workers or any or similar kinds of professional people that helped you?
I wasn't, mainly because we just didn't have time. We were running from one medical crisis to another, trying to just keep on top of it, keep going day by day. you do feel very alone with this, and I think that's a big part of it. Even though there are so many lung cancer cases, people don't really like to talk about it. They're embarrassed about it, or they blame themselves, or they think something's wrong, and it's just not out there like the other kind of cancers. So it would have been nice. It would have been nice. And for me, that's part of sharing my story, to say, you know, it happens to normal people, to normal families. It can happen to anyone. It's not your fault.
So loneliness, feeling isolated and vulnerable, which are, you know, you really need support.
Exactly.
Yeah. You know, I was thinking when you were saying that, for some reason, the stigma still prevails with lung cancer. There used to be a stigma associated with breast cancer 40 years ago. No one wanted to talk about it, right, Phyllis? I mean, you and I are in the same age group, and you know, because people felt, well, if someone has breast cancer, you can even catch it. I don't want to touch somebody who has breast cancer. I mean, this sounds crazy, but we're talking about in the 60s, even early 60s. So what about? But then some of these, like the president's wife, other well-known, famous women, celebrities said, you know, I have breast cancer, and that really helped the whole movement. What about lung cancer? Are there any well-known? Yeah.
Yeah, there are. You know, we are keeping our eyes open.
Celebrities.
All kinds of celebrities to speak out. And we are getting more and more people. I'm not really, you know what, like you said, my age group, I'm out of the pop culture. And if you mention a name, I wouldn't even recognize it.
Okay, but you know what? If it's a celebrity, you would recognize it. And I don't think any of us, or you're not able to name one, or neither is Betsy. I mean, somebody who's really famous. And we're not talking about a rock star, but just somebody really well known, a political figure, for instance. No, nobody comes, nobody.
Well, Senator Chuck, he's not a senator anymore, Secretary of Defense, Chuck Hagel, he helped pass, he helped co-sponsor, I should say, the first legislation that didn't get passed for lung cancer research. And so he was up there, and he's, I guess, the most famous person that I can think of. But I think Valerie Harper, does that sound familiar?
Valerie Harper, yes, she's the one. She was on, the story Mary. What was the name of it?
Mary Tyler Rhoda.
Yeah, she has lung cancer.
Yeah, I think so. Go ahead.
No, I mean, Luke Stein, who's our board op, he just passed me a note saying, didn't somebody, and I see he said Duke, I think, but I can't read the last name, so go ahead.
The Duke is John Wayne.
Oh, John Wayne.
Yes. I thought he died of lung cancer. I could be misinformed on that.
I think you're right.
Okay.
Yes. But no one's really taking it on as their cause, as the thing that they're going to fight for and raise awareness for. Even if they do have lung cancer, they kind of push it aside and don't fight for it.
Exactly. Because we're struggling to say, did he or didn't she, or do we know? I mean, yeah.
It's not like how Angelina Jolie came out and all those other celebrities, and they get such attention, and it's on the cover of, People magazine. There's not something like that for the other types of cancer, not only lung cancer, but some of the other cancers that just aren't given the amount of attention, funding, or resources and support that some of the more popular, I guess, cancers are given.
So that's up to you, Phyllis and Betsy. Come on, get out there, get some of these celebrities involved, and I bet you could.
Yeah, well, our national office is supposed to be keeping on top of this. And
you're laughing.
Yeah, and they're reaching out to people as they become known to them, because they have in mind various publicity campaigns that they could help with on the national level, and that's something that I can't offer. But certainly if they would get involved on the national level, we can tap into them to come to our area and help us out, to get people to come to awareness events.
In New York State, what is the Governor Cuomo? Is he doing anything, or is he involved in this Lung Cancer Alliance?
No. As a matter of fact, the New York State budget has in it research dollars designated for diseases like breast cancer and autism, and not to take away from that, that's fine, but it doesn't have any designated for lung cancer. So that's where we are.
And it seems like we've been this way for quite a while. I mean, you've been involved, since your diagnosis, we're talking about 10 years at least, and
Yes.
yeah, from your own personal involvement. And what about you, Betsy? When did your sister die?
In 2010, so about 3 years ago.
How about the family? I mean, now, you know, was this your only sister or only sibling? So now you are the sole sibling left.
It's unbelievable. I still can't believe it. I think for my grandparents, it was really the hardest, and it's still hard to wrap your head around. And the whole thing was just a roller coaster of up and downs, up and down. She got better, and then something else happened, and then she'd get better again, and it was very difficult. And from the time of her diagnosis until she passed away is less than a year, which is pretty common, unfortunately, for people when they talk about lung cancer stories. It all happens very, very quickly.
You know, we talked about the guilt. Is there of the person who, or the victim, I'm saying, feels like that maybe they were responsible for their own lung cancer. What about the family? Is there survivor guilt, or we should have done something, or we could have recognized that perhaps she was sick sooner, or all those kinds of questions? Or how do you handle that?
Oh, yeah. Oh, definitely. Now you look back, and she was tired and she was sick for years. But when you're living with somebody, you feel, oh, I'm just overworked, I just have a cold, the normal everyday stuff that everybody goes through, and you can't see it till after the fact. And then my mom's always like, oh, she didn't live in the apartment where her neighbor smoked, maybe it wouldn't have happened. If she didn't do this, maybe it wouldn't have happened. It's just, you don't know what caused it or what happened, and it's hard because it keeps replaying over and over.
So what would you suggest to families who are going through that, who are sitting there, that their loved one, which in this case, a young, a daughter or a granddaughter or a sister or brother dies, so that you can, I think you're always going to go through some of that, but to not let it take over your life for...
Yes, I think that we can't play the should-have, I could-have game, because that only brings upon guilt, and we don't need that. We need to move forward with our lives and with their memory, and playing the guilt game isn't going to get us anywhere, and that's where social workers can help people. People who do feel, oh, I should have done this, I could have done that to help, or to help myself. And it doesn't get us anywhere. We need to move forward.
Yeah, I think that's good advice. But I think some of us, as you said, I mean, this is a place for social workers where you can help, because some families can do that easily and other families can't. They just get stuck.
Yeah. I think everyone deals with it differently. For me, working with the Lung Cancer Alliance and putting my story out there and being positive really helps. But for my fiance, it just brings it all back, and it really, doing those things don't help him. So everyone deals with it differently. And just because you don't want to go out there and plan an event or be part of an event, there's other things you can do and other ways you can help. And the Lung Cancer Alliance is a great resource to start. And they'll help you find something that you'll feel comfortable doing.
See, I think that's a really good point, and I think a lot of us tend to, whether it's lung cancer or any other disease, we all respond to it differently. And there are those who, like you said, Betsy, who want to get out there, and it doesn't make them sad, but it makes them feel good about doing it. Other people get depressed about it. You want to take a short break right now?
Yeah.
All right, we're going to take a break right now because we've been going now for, we're past our break time. We're usually, Phyllis, stay on the line with us, and we'll be back in a minute. I'm Kathryn Zox, your social worker with the microphone with Alyssa Lotmore, and we are the Social Workers Radio talk show. Don't go away.
When I grow up, I want to be a new pair of blue jeans.
When I grow up, I want to be a kid's first computer.
When I grow up, I want to be a glass countertop in a new home.
When I grow up, I want to be a kid's best birthday present.
When I grow up, I want to be a football football stadium.
When I grow up, I want to be a warm fleece on a cold day.
When I grow up, I want to be a fancy backsplash.
I want to be a bike that races around the country.
When I grow up,
I want to be a bench on a forest trail.
I want to be a rocking chair on a sunny porch.
I want to be a skyscraper. I want to be
When I grow up, I don't want to be a piece of garbage. And if you recycle me, I won't be.
Give your garbage another life. Recycle. Learn how at iwanttoberecycled.org. A public service advertisement brought to you by Keep America Beautiful and the Ad Council.
A single ember from a wildfire can travel over a mile. You can't control where it lands, only what happens before it does. Simple steps to adapt to wildfire helps keep this from turning into this. Your home is better protected from wildfire when your whole community is prepared. Visit fireadapted.org for tips to get started today. A public service message brought to you by the U.S. Forest Service and the Ad Council.
You're listening to The Social Workers on WCDB Albany.
We're back. I'm Kathryn Zox, your social worker with a microphone, and you're listening to the Social Workers Radio Talk Show. Alyssa Lotmore is here with me. She is a graduate of the School of Social Welfare, MSW, and my co-host, Betsy McPhail, and Luke Stein. Today we're talking about lung cancer. November is Lung Cancer Awareness Month, and joining us this morning to discuss the Lung Cancer Alliance program and also the program Lung Cancer at Albany Medical Center is Dr. Thomas Fabian. He is chief of Albany Med's section of thoracic surgery and director of its multi-specialty lung cancer program. Welcome to the show. Nice to have you on this morning, Doctor.
Good morning. Thank you for having me.
It's great having you because we were told you weren't going to be on the show, so this is a great surprise because I remember the show from last year and you were fantastic in terms of So, okay, we've been talking to Phyllis Goldstein and Betsy McPhail and kind of getting into the personal stories of those who have been diagnosed with lung cancer. But now tell us about what's going on at Albany Med, the research, what's happened in the past year in terms of lung cancer awareness.
Well, I think thanks to groups like Lung Cancer Alliance, there's growing awareness. As you mentioned before, November is the Lung Cancer Awareness Month. And lung cancer awareness is becoming more important since over the last few years since we've developed and protocols for screening of lung cancer patients.
So the protocols, are they different? Or are you talking about early diagnosis? Because as I understand it, that's one of the problems with lung cancer. It's diagnosed late stage, and that's why so many, or 80% of the patients die, and you want to change those statistics?
Yeah, absolutely. That's always been one of the problems with lung cancers, because by the time the patient has symptoms, many have already progressive disease. And so in the past, we've been most fortunate with the patients who are identified by accident. The person who trips on a box and their shoulder hurts, and they get x-rays and we find a lesion, and it's an early, very curable lung cancer. And really, screening for all cancers is with the intent of identifying patients who are more likely to benefit from treatment and more likely to be cured. And so lung cancer screening really does flip that paradigm, and the majority of patients who are found by screening programs are at curable stages. And that's a dramatic improvement, and one that we've all been waiting for a long time to come.
But what is the screening process? I'm thinking of myself. I go every year to my primary care physician, and I have my checkup. I was just there recently. I don't know that she did anything particular in terms of lung cancer screening in the same way that, say, we do for breast cancer, mammography, self-examinations, and then the physician examines you. So what would you do if you go to your primary care physician?
Yeah, so absolutely. And part of our job is to educate primary care providers as well, who are responsible to understand all of these algorithms for screening for breast cancer, colon cancer, prostate cancer, and so on. And in lung cancer, the screening is indicated for high-risk individuals, and those are patients who who are over 55 years of age, those with significant smoking history or other mitigating factors, including family history, etc. And the screening protocol basically now is a CT scan of the chest. One of the difficulties over the data's been there for a few years now that clearly demonstrates a marked improvement in survival and a dramatic increase in overall survival in patients being screened with CAT scans versus those that were screened with X-ray alone. And so now the battle has been to raise awareness and encourage healthcare insurers, the government, to endorse screening and to reimburse the patients for screening.
Dr. Fabian, what about, and we've been talking about this from a layperson's perspective, but stigma, how are physicians how do you as a physician help to overcome this stigma of lung cancer? Because it is out there.
Yeah, absolutely. And there are a number of stigmas in other diseases. Not all malignancies. Most malignancies we feel are brought on by, bad fortune, etc. But a number of malignancies are smoking related. It's just so easy to label smoking as to lung cancer. So the stigma isn't there for bladder or pancreas and some of the other tumors that are provoked by smoking. But it certainly is in lung. I think one of the important things, and Phyllis is a great example of this, is that many of our lung cancer patients are lifelong non-smokers. And realizing that the second most common cause of lung cancer is radon exposure, and of course occupational exposure, and there's been new legislation to help reduce those risks. And getting that out, because I think that sort of makes us realize that it's just like any other tumor. And although there are risks that we may have, a lot of it is just bad luck.
Now, another question is, what about treatment? Because I was interviewing it was a breast cancer survivor, and she was talking, this is another show, but talking about the options for treatment, and that it's not so cut and dry. You think you go in, you're diagnosed, and then the physician will tell you, well, this is what we're going to do, chemo, radiation, or whatever. But what about for lung cancer? Are there options for treatment? Do you sit down with your physician? Do you talk about it? Or is it there's just one protocol if you have lung cancer, one kind of protocol for treatment?
No, absolutely. It's why I love medicine. It's the artistry of the science. So we take the knowledge that we have and then we integrate it for a patient's benefit. So every patient is different, and there are values and drawbacks to multiple treatments. So any one person may receive an opinion about different ways to treat them. They may be presented in different ways that one option is not viable, or that they have a multitude of choices. And that's something that's also new. I think that extends beyond just surgery versus non-surgical treatments, but also in the non-surgical candidates, their choices regarding chemotherapy and their choices regarding radiation therapy, and those choices allow them to really make some important decisions about how they want to treat this and how they want to approach their management.
What do you do? Can you give us an example, like actual, obviously without identifying the patients, but different kinds of treatments for different types of patients, how they they present themselves in different ways, like specific examples.
So I mean, the data to simplify, we define lung cancers in 4 basic stages, and we know that the best benefit for a stage 1 or stage 2 lung cancer is with surgical resection, and by best benefit I mean the most likelihood of curing that patient. But in certain circumstances, often due to frailty or older age, or perhaps a patient's lack of interest in a cure but maintenance of quality of life. If I meet a 98-year-old, their goals may be very different than a 40-year-old's. And there are alternatives to surgery in that way, including chemotherapy, radiation therapy, or even stereotactic radiotherapy. But for the early stages, typically surgery is the most frequently pursued treatment. For the more advanced stages, it's an integration of all of those specialties and choosing how to integrate those treatments.
Do you involve the patient and the family, or significant others, partners, loved ones? Is this can be somewhat of a group decision?
Absolutely. I think that I stress to the patients and their families that it's not just the patient who's going through it. It's also their loved ones, their families, and those things make a difference, particularly when you start to talk about perhaps older companions who are dependent on one another to maintain their independence or quality of life. And so I mean, ultimately, the patient is the boss, and they get to make their decisions, etc. But the involvement of their family is critical in helping that patient make those decisions.
Alyssa Lotmore, who's my co-host and an MSW graduate here at the School of Social Welfare, she's sitting here with me, and she's just ready to ask you a question. So go ahead, Alyssa, ask the doctor.
It's more of when you're talking about the families being a part of when determining the treatment. And I've known some people, actually one person who currently has lung cancer, who is choosing not to really go through a lot of the treatment. And it's hard on the family to watch this person, and they want them to do treatment. They want them to do the chemo and the radiation. And the doctor had told the patient that it wouldn't extend, that it was still a terminal diagnosis, but treatment might extend a month or two. And, the family's holding on to that, but the person says they don't want to. And how do you help families get through that? Is there resources for families when the person, diagnosed decides that they don't want to do a treatment?
Sure. Well, I think it's actually talking about the pros and the cons, and the reality is in that small story, what I understood was that the patient made a brave choice and was given options. Wasn't told that they couldn't treat him, but the patient was given options and has chosen for whatever reason to do it this way. And I think you have to encourage the families to support those decisions, and no one wants their loved one to face the end and so on. So those are normal responses, and I think the more you talk about it, the more the examples or possibilities are reinforced, the more accepting everyone is. It's not just the patient who goes through the denial, acceptance, bargaining, depression cycle of information. The family has to go through that too.
The end-of-life kinds of decisions that people make, I'm really interested in. I had a friend who just recently died of ovarian cancer, and her prognosis wasn't good, but there was kind of a false sense of hope, I always felt. This is someone I've known since she was 9 years old. And the last 6 months, having chosen to go through the chemotherapy and the radiation and everything, were horrific. And she died. And I was with her in hospice. And I kept thinking, is this the choices? And I'm thinking of lung, as you're describing, say, stage 3 or stage 4 of lung cancer. As a physician, I'm really interested in kind of in the ethics or the morals of helping people come to those decisions. Like, or how much do you say, or what do you say?
Well, I think those are physicians have personal attributes that may be different. Obviously we all have the same goal and task, but the way we communicate is very important. And for some people, and for some patients, they may not always get. It's hard to take away hope from somebody. And we're getting a little bit far away from lung cancer, and I'm very sorry to hear about your friend. But I think that some of these people, they pursue that small chance, that miracle, that hope, and I think that's appropriate for some people and inappropriate for others. But everyone has to come to that realization on their own terms, and we have to help them make the right choices. Sometimes we will help them in a good way, and sometimes we won't. But separately, one of the things when we talk about lung cancer and some of the new innovations, one of the biggest progresses in the fight against lung cancer is some of these mutations that are allowing us to dramatically affect patients who previously had really poor prognoses and were not good candidates for any treatment. And that's a very exciting part of the field of lung cancer treatment now.
All right, so talk to us about that specifically, because that's the hope.
Absolutely. Well, I think just as technology has exploded in cell phones and everything else, it seems, that is happening now with genetic testing of patients, genetic testing of their actual tumors, and identifying patients who just 10 years ago would be sort of given a very poor prognosis and been given the alternative, no treatment versus chemotherapy, and many would choose one or the other, and with perhaps very little benefit. Some of those patients who in the past we had dismal outlooks for, now with genetic testing of their tumors, we identify sub-select patient groups, and we have medications that can dramatically change their prognosis, their survival, and their quality of life. And that's really exciting. And I think we're really just on the cusp and the verge of a lot more changes. It used to take, I don't know the exact numbers, but it used to take, say, $1 million to do a genetic test on somebody's body and their tumor and identify some of these features. And now it's a simple software program that gets done on a computer. So those innovations in technology are just opening the door for new treatments and exciting changes.
Well, that's exciting, and I think it really helps when, getting back, and we're going to have to say goodbye, but this whole issue of awareness, when the public becomes aware, like what you're doing, making them aware of these things, I think people are less reluctant to go in and to get tested and to recognize that perhaps they need help, because, with all this, as you say, positive kinds of technology in terms of diagnosis and treatment, it makes us less scared. Information is power. We feel good about it. So
absolutely,
yeah.
And choices are power, which is what we were talking about before, and that's an interesting point as well. When populations have been screened, and it includes people who are at risk for lung cancer and those who are at low risk for lung cancer, it's interesting that what you find is that the patients who are higher risk, former smokers, elderly, secondhand smoking exposure, occupational exposure, family history, they are the ones who are least likely to be interested in enrolling in a screening program, and more pessimistic about their potential benefits from that screening program. And that's part of the information and understanding of the disease, etc.
Well, it's been a pleasure talking to you today, and as always, lots of new information. You have to come back next year. We'll follow the progress. We've been talking to Dr. Thomas Fabian, Chief of Albany Med's Section of Thoracic Surgery and Director of its Multi-Specialty Lung Cancer Program. Thanks again for being on the show.
Thanks so much for having us.
Great. We have, just a couple more minutes, and I think we've covered as much of the topic as we can today in 1 hour. But I think we're all, at least I'm a lot more aware of what's going on.
I think the statistics were astounding to me. I didn't realize it was that high. And for something that high, and there's so many deaths and diagnosis each year, to have not as much attention and funding toward it is sort of a shocking realization that we really need to have more awareness and more support, more people come out to really give put faces to this disease.
Put faces to the disease, that's it. And we need those celebrities. Where are you? We're going to say goodbye because we have Zsa Couture. Now she has an interesting outfit. I always have to. Her outfit today is kind of like, what is that? It is sort of like a jumpsuit.
Pajamas?
Pajamas?
It's my rainy day onesie.
Oh, rainy day onesie. I only knew onesies for onesie for. I like that. I have to ask her where she got it. Anyway, Zsa is coming on in a few minutes, and we're going to say goodbye. We are the Social Workers, and this is the Social Workers Radio talk show at the University of Albany School of Social Welfare. I'm Kathryn Zox with Alyssa Lotmore, Betsy McPhail, and Luke Stein. Have a great week, and we will see you next Thursday.